Okay. My name is Ben Surdy, and I'll be doing my health campaign presentation on diabetes 1 and 2. So diabetes 1 and 2 plus my campaign. Diabetes 1 and 2 is a huge problem we face in the United States today. The big problems between actually both of them is attitude and lack of education. So someone with type 2, they might just not care. They might not want to fix their health, what they need to do to fix their health. And then for lack of education, they might get type 2 diabetes because they didn't know if they even could get it until they had it. Similarly with type 1, they know a little bit earlier, but maybe they don't get the education they need on how to treat it properly for the rest of their lives. And then they don't really see that there are problems occurring until much later. So for my campaign, there will be two sides of it. One will be helping education integration into the high school system. So think health class, sex ed, those classes that are mandatory to high school experiences. And on the other side of things, we need to increase access to digital healthcare providers and educators if someone doesn't want to or have access to in-person meetings with educators. So why this matters? So put it simply, diabetes is the body having problems turning food into energies, and this results in high blood sugar levels, too much sugar in the blood. So type 1 is what you see when someone's not born with it, but it develops pretty early, and there's not really much you can do about it. There's nothing to prevent it. Type 2 is what we normally think of when we think of diabetes. This is when you have people who are obese or have really bad health choices, and it results in type 2 diabetes. So type 2 is actually the one that's fixable. You can get rid of type 2 diabetes by fixing your health decisions. Type 1, you can't do much about it, can't get rid of it. However, you can actually live a very normal and healthy life as long as you make the right choices as you go on in life. So from my experiences, I had one friend growing up who was type 1. I would see him check his blood sugar levels all the time. It was kind of eye-opening. I'd always see him. He was really good about it. So I'd always see him, checking his foods, making sure he's eating the right things. And then I've had a couple family members with type 2. I've had some get rid of it, which is really nice to see. And I've had some not really care as much. And it's kind of sad. They kind of just let it take over their life a little bit. So for my interviews, I had 3 participants, 6 interviews total. So each one got 2 interviews. It's about 3.5 hours total. I asked each of them 14 questions, 8 in the first interview and 6 in the second. I like to see how I could come back a couple weeks later, and because they had thought about it, they could answer things a little bit differently. I took 7 pages of notes. So who I interviewed. First, I interviewed a 23-year-old male Caucasian from Seattle, registered nurse, trauma surgery nurse. For the purposes of this presentation, him and the next one was 51-year-old female Caucasian, San Diego, surgical ICU nurse. Those are basically the same thing. They're a little different, but for this presentation, it doesn't matter too much. She actually put me directly in contact with this last interviewee, 40-year-old female Caucasian from San Diego, certified diabetes educator. I didn't even know this was a job. And it was really eye-opening to see what she had to say. They all had a lot to say, and all had a lot of experience with diabetes. So my best interview questions, I believe, were what makes treating people with this illness different or interesting? What communication skills are most important when treating people with this illness? This is when I got a lot of stuff that related to the class. Third, what is the hardest part about treating this illness? This is when I got some of the grosser information about how the body changes when you have diabetes. And finally, what are the biggest aspects about this illness that need changing? And that was really good to kind of figure out what I wanted for my health campaign. So for the male nurse in Seattle, main thing he had to say was everything changes when you have diabetes. It's basically a different human body. You have to treat everything way differently, which he said was actually kind of cool for him to do and learn. But if you really think about it, it's kind of sad that everything changes just from this illness. So it's really, really important. He also said he didn't communicate with them because in his line of work, it was all surgeries, high stakes. He didn't really have much to talk to them about. He said the hardest part was people don't care. And something he said that was really sad about this was he doesn't think there's room for improvement in the healthcare system with diabetes. It's the patient's fault. He said they have the access to the care and they just don't want to listen. So then I went to the female ICU nurse in San Diego, and she talked about switching from orals to insulin drips. So when they come in the hospital, they take them off all their oral medication for diabetes, put them straight on insulin, kind of an easier way to regulate it. For communication, she talked about a little bit more. She said there's a lot of bedside manner because these people are in a lot of pain and they're also very scared. And she said because they're scared, she uses a lot of shared experience to kind of ease them through it. But again, she talked about zero motivation from these patients. She gave me a story about Coca-Cola, and it was a man who was in the ICU for the second time in like a pretty small amount of time. and he actually paid his friend $100 to sneak him in one can of Coca-Cola, which is really upsetting. She also talked about a food problem, which is the hospital probably should give them food with basically no carbs in it, but because they want good testimonials and they want their patients to feel comfortable, they actually give them food that's probably not the best for them while they're in the hospital. Finally, I talked to the female diabetes educator from San Diego. She talked about it's really hard to explain the importance to people with type 1 because they don't show signs until it's really bad. And they don't really understand, they don't feel different if they're not doing the correct things for their body. In terms of medical and mentals, she talked about patient-provider relationships a lot because her goal is to educate. She can actually kind of figure them out, and it's a lot more mental aspect rather than just this is what's happening in your body, this is what you need to do. It's how can we get this done in the best manner that best fits your lifestyle. Same with cultural context. She has to realize that some people come from these backgrounds where their family is just used to having type 2 diabetes or type 1 maybe and not caring about it. And that's just something that she has to work around, but you can't ignore it because it's how people grow up. Differing patients. So a lot of patients come in with internet informed. So some people only need to, be talked to once, and then for the rest of their life, they know exactly what they're doing. They know how to eat. They know how to be healthy, and for the rest of their life, they're good. Some people get type 2 diabetes, and it scares them a lot, and they fix everything, and they ask for questions, and then they get rid of type 2. But she said there's a little bit of a problem with the digitized healthcare system in terms of diabetes. There's not much going on there. There's room for improvement, and what's on the internet sometimes isn't the best for every person's body. So her job was basically to personalize the same care to different people. And she said it's very rare, but she did talk about strict paternalism. Sometimes she would say, especially with type 1, she would make it seem much more urgent than it actually is. Maybe this wouldn't come up for 10 more years, but if you say that, people probably aren't going to change what they're doing. So my understanding into the campaign. So my 5 key concepts that I had were education, quality of life, cultural context, bedside manner, and digitized patients. So education, clearly the education needs to be better. Quality of life, especially with type 1, you have to kind of change your quality of life a little bit to make sure you're healthy, especially with type 2. If you get rid of the type 2, quality of life improves a lot. Cultural context, I already talked about, same bedside manner. Digitized patients, I want more digitized patients in my health campaign. It's kind of the whole point of it. What I learned from the interviews is some people just don't care about their health, and there's not much you can do about it. But what I also learned is some people don't have the access to the proper education, and that can be fixed relatively simply. So in my campaign, again, every American needs to be educated on diabetes, and every American needs better access to continued care. So my full campaign, so high school education integration. So we need high-level educators traveling the United States through high schools to teach the high school educators how to teach this to their own students. And that can be broadcast like after that forever. And then access to further education. These teachers need to give resources to these students when they need it, when they tell them about diabetes and educate them on it. So the campaign, we're targeting high schoolers. Our objective is to educate those without the disease, so internet literacy as well, make sure they know how to use the internet to find information about this, give the resources they need, and the impact we need, type 2 diabetes prevention, also resources for every American to use, and less deaths in total from type 1 or type 2 diabetes. So the timeline we're going to use, initial 2 years of education. There's about 27,000 public school high schools. I want to use 300 educators. No certification needed because they're not actually educating about diabetes health per the individual. They're just talking about it in general. So that's only one school for every 8 days to teach this curriculum to the teachers. From then on, the teachers can handle it. After 2 years, education continues for the foreseeable future. Don't have to worry about it. Diabetes educators can have contract work, especially on this new digitized platform. But once they're on it, they can kind of do it on their own and just do it per client basis. So the budget is 50 million. So 300 educators, $50,000 salary, 2 years at 30 million. To make the actual digitized platform, that'll be $10 million. And diabetes education for the first couple years, maybe give them bonus incentive to get on the platform, get new patients, get involved. And once they're there, they kind of know what's going on. So communication plan, kind of just through high school, pretty simple. Each year, new students, new communication. Purpose, passion, give permanent assistance, help with the problems, and grant access to education and better for every single American. Again, themes and comms, communications, there it is. What I learned about health communication, everything has to be individualized. Sad, some people don't care. But what I also learned is over the past few months, I've learned a lot about a really small aspect of health, which is just diabetes. It's really scary to think that I barely did anything in terms of research, and I found so much, and there's so many other aspects of both health and health communication. Thank you.